this lecture, we are going to discuss treatment of VKC and AKC. The management of VKC does not differ substantially from that of AKC, although the latter is generally less responsive and requires more intensive and prolonged treatment. We will first of all discuss some general measures like allergen avoidance if possible. Patch testing sometimes is useful but often gives non-specific results. Cool compressors may be helpful. Lid hygiene should be used for associated staphylococcal blepharitis. Moisturizing creams such as E45 can be applied to dry, fissured skin. Bandage contact lens wear to aid healing of persistent epithelial defects. Then local treatments like mast cell stabilizers, for example, sodium chromoglycate, metochromil, or lodoxamide, reduce the frequency of acute exacerbations and the need for steroids, and so form the basis of many regimens, but are seldom effective in isolation. Several days to weeks of treatment are needed for a reasonable response, and long-term therapy may be needed. Lodoxamide is not licensed for long-term use. Topical antihistamines, for example, amidestine, epinestine, levocabestine, bepotestine, when used in isolation, are about as effective as mast cell stabilizers. They are suitable for acute exacerbations, but generally not for continuous long-term use. And courses of several preparations are licensed for use only in courses of limited duration. A trial of several different agents may be worthwhile. Combined antihistamine and vasoconstrictor, for example, entazoline with xylometazoline, may offer relief in some cases. Then combined action antihistamine and mast cell stabilizers, for example, azelastine, ketotifen, and volopatidine, are helpful in many patients and have a relatively rapid onset of action. NSAIDs or non-steroidal anti-inflammatory preparation, for example, ketorolac and diclofenac, may improve comfort by blocking non-histamine mediators. Combining one of these with a mast cell stabilizer is an effective regimen in some patients. Topical steroid, for example, chloromethalone 0.1%, rimaxolone 1%, or prednisolone 0.5%, loteprednol tabinate 0.2% or 0.5% are used for severe exacerbations of conjunctivitis and significant keratopathy. Reducing conjunctival activity generally leads to corneal improvement. They are usually prescribed in short but intensive, for example, 2-hour initial courses, aiming for prompt tapering. Although the risk of elevation of intraocular pressure is low, monitoring is advisable if long-term treatment is necessary. Stronger preparations as prednisolone 1% can be used, but carry a higher risk of steroid-induced glaucoma. Shield ulcers are often refractory to topical steroid treatment. Then comes the role of steroids ointment. For example, hydrocortisone 0.5% may be used to treat the eyelids and AKC. Though with eye drops, the duration of treatment should be minimized and the intraocular pressure monitored. Antibiotics may be used in conjunction with steroids in severe keratopathy to prevent or treat bacterial infection. Acetylcysteine is a mucolytic agent that is useful in VKC for dissolving mucus filaments and deposits and addressing early plaque formation. Immunomodulators now have a very important role. Cyclosporin 0.05% to 2% between 2 and 6 times daily may be indicated if steroids are ineffective, inadequate, or poorly tolerated, or as a steroid-sparing agent in patients with severe disease. The effect typically takes some weeks to be exerted, and relapses may occur if treatment is stopped suddenly. Irritation and blurred vision are common. Calcineurin inhibitors show increasing promise as an alternative to steroids in the treatment of allergic eye disease. Tacrolimus 0.03% ointment can be effective in AKC for severe eyelid disease Installation into the fornix has been effective in modulating conjunctival inflammation in refractory cases. Tacrolimus 0.1% ointment is particularly useful when applied topically in patients with shield ulcers and corneal epitheliopathy and can be used without topical steroids. Factors associated with a poor response to tacrolimus include the presence of a giant papillae and palpebral abnormality. Then comes the role of supratarsal steroid injection, and it may be considered in severe palpebral disease or for non-compliant patients. The injection is given into the conjunctival surface of the anesthetized everted upper lid. 0.1 ml of betamethasone sodium phosphate 4 mg per ml, dexamethasone 4 mg per ml, or triamcinolone 40 mg per ml is given. Systemic treatment involves oral antihistamines, which help with itching, promote sleep, and reduce nocturnal eye rubbing. Because other inflammatory mediators are involved besides histamines, effectiveness is not assured. Some antihistamines, for example loratadine, cause relatively little drowsiness. Antibiotics, for example doxycycline 50 to 100 mg daily for 6 weeks, azithromycin 500 mg once daily for 3 days, may be given to reduce blepharitis aggravated inflammation, usually in AKC. Immunosuppressive agents, for example steroids, cyclosporin, tacrolimus, azathioprine, may be effective at relatively low doses in AKC, unresponsive to other measures. Short courses of high-dose steroids may be necessary to achieve rapid control in severe disease. Monoclonal antibodies against T cells have shown some promise in refractory causes. Other treatments that may be effective in some patients include aspirin and VKC allergen, desensitization, and plasmapheresis in patients with high serum IgE levels. But this is avoided in children and adolescents due to Reye syndrome. Surgical management include superficial keratectomy and surface maintenance or restoration. Superficial keratectomy may be required to remove plaques or debride shield ulcers and allow epithelialization. Medical treatment must be maintained until the cornea has reepithelialized in order to prevent recurrences. Excimer laser phototherapeutic keratectomy is an alternative. Surface maintenance restoration surgery such as amniotic membrane overlay grafting or lamellar keratoplasty or eyelid procedures such as botulinum toxin-induced ptosis or lateral tarsorrhaphy may be required for severe persistent epithelial defects or ulceration. Gluing may be appropriate for focal punched-out corneal perforations. That's it for the treatment of VKC and AKC. We'll conclude this lecture here. And if you like the lecture, please press on the like button and subscribe to the channel. Thank you all.